Thank you all for taking a little bit of your time this evening away from the meeting to enjoy a little bit of information about myeloma and then hopefully soon thereafter have some dinner. I thought in particular what I would try to do is to focus on some of the interesting things that were presented at this past ASH meeting back in December. And I wanted to cover a couple of areas, including some updates on asymptomatic myeloma, then therapy for transplant ineligible as well as eligible patients, then to look at some of the new drugs that are emerging in the relapsed and also relapsed refractory setting, and a little bit about supportive care, and hopefully convince you that the future for myeloma therapy is even brighter than it currently looks. Let's first start with smoldering myeloma, and right now the standard of care in this setting is to do watchful waiting. But we do know from some of the studies from Bob Kyle and his colleagues at the Mayo that there are some folks that we can identify who are at especially high risk of progression, especially people with an M protein over about 3 grams per deciliter. They have about a 10% per year for the first 5 years risk of progression. So about half of them over 5 years will progress to symptomatic disease. So the Spanish have been doing a study where they randomize these people either to standard of care, which would be observation, or to lenalidomide and dexamethasone at the standard dose and schedule. With lenalidomide, the dexamethasone was a little bit lower at 20 on days 1 to 4 and 12 to 15, and this was for 9 cycles, followed by a dosing of lenalidomide, sort of like maintenance after transplant. The response rate with this combination, as you would expect, is even better than it is in patients who have symptomatic myeloma. You can see an overall response rate of about 91%, and about a third of folk have at least a VGPR or better. This is within the 9 cycles of therapy. Time to progression is shown here, and you can see that in the blue curve, people who had just observation alone had a substantial time to progression of about 25 months, so about 2 years actually, maybe a little faster than one would expect, whereas the patients who got lenalidomide and dexamethasone had a much lower risk of progression. And in fact, some of the downticks on the curve were not because of progression to disease, but actually either because of discontinuation of therapy or withdrawal of consent. So at least as of the time of the presentation, only 2 patients had actually progressed to symptomatic disease. And several of the patients who were on just watchful waiting actually progressed with bone disease. So certainly something that we need to watch for in the future, although I'm not sure that I would yet recommend doing this routinely on all of our patients. And overall survival is still very good for both groups, and the main grade 3 toxicities that were seen were probably what you would expect with your experience with lenalidomide and dexamethasone. Moving on now to patients who are not eligible for stem cell transplantation, we have a number of different options that we can use for these folks, and probably the category 1 recommendations, at least according to the NCCN, are combinations like MP with thalidomide and MP with bortezomib, as well as lenalidomide and low-dose dexamethasone. One new option to consider may be melphalan, prednisone, and lenalidomide. You probably know about this study, which Antonio Palumbo presented, a 3-arm trial where people got either MP followed by placebo, or MPR followed by placebo, or MPR followed by lenalidomide maintenance. An update of the data were presented at ASH, and what was shown is that progression-free survival, which was one of the primary endpoints, was better for MPR followed by R. Actually, it was more than doubled at 31 months compared to 14 months for MPR and 13 months for MP. And if you do a landmark analysis looking at what happened to people only after the beginning of maintenance therapy, You can see, as you probably know, that it seems like the maintenance therapy is mostly what contributed to the benefit of the MPR plus R people. Overall survival is not yet different. The numbers are very good for all of the three groups, but it may be that with additional time, given the PFS difference, that there will be some further separation of the curves because this trial is not yet mature. And adverse events of note were, of course, things like cytopenias, which were a little bit increased if lenalidomide was used. And there were a couple of cases of AML and MDS on the MPR and MPR followed by R arms, and I'll touch on that a little bit later when we talk about some of the maintenance data. Another option to think about for non-transplant patients are some of the bortezomib-based combinations, and there are a number of them that you can choose from. This study was actually an interesting one because, first of all, it was a phase 3 randomized comparison between 3 different bortezomib combinations, and it also was a community-based study. So this was not done at places like MD Anderson, where we sometimes get accused of cherry-picking our patients, and people do very well there. So these are the kinds of people who would walk into your office on a daily basis, and they were randomized either to bortezomib and dex, or to bortezomib thalidomide and dex, or to the standard VMP regimen in cycles 1 to 4, and then cycles 5 to 8 was a reduced dosing, and then all patients were followed with some kind of bortezomib maintenance. Here you can see the best response data. So all of these regimens had excellent overall response rates as well as CR and near CR rate, although maybe there was a slight trend favoring the VTD combination, which may have had a slightly better overall response rate and response quality. Progression-free survival, however, was roughly equivalent for all of them within the follow-up that was available. And adverse events, I think, is another area where you probably could more easily pick a winner. You can see, as you would expect, that with VTD there was more fatigue and also a little bit more peripheral neuropathy. With VMP, there was a little bit more neutropenia, and with VD, there was a little bit more of a problem with pneumonias. So if you wanted to balance out the toxicities versus the benefits, given that the PFS was similar for all 3 arms, you might favor either the VD or the VMP arms and go with those for your transplant ineligible patients. And there also was an interesting separate abstract that looked at the quality of life or patient-reported outcomes. And again, as you would suspect, patients who got VTD, because these were an older patient population, tended to have a decline in their quality of life, although it did later on improve somewhat, whereas people who got VD or VMP had a more stable outcome, and therefore perhaps you would pick again those two because of improvements in quality of life. Moving on now to patients who are eligible for stem cell transplantation, I think one of the more interesting studies in this category was the combination study that was done by the Dutch and also the Germans, where they randomized people to VAD versus PAD, which was basically bortezomib instead of vincristine, and then all patients were supposed to go on to stem cell transplantation with an auto transplant, and then the German study part had actually also the potential for an allogeneic transplant. Looking at some of the response rates, as you would probably expect, you can see that the PAD arm had a better overall response rate, 78% versus 55% just after induction, and about a tripling of the VGPR rate or better. That improvement was maintained after stem cell transplant and also after maintenance therapy. If you look at the maintenance therapy, the VAD arm got thalidomide as maintenance, and the PAD arm patients got bortezomib as maintenance, and in both arms, maintenance did improve the response quality in a substantial proportion of patients. Overall survival data, we still need longer follow-up here, certainly, but it does look like the PAD arm is having a greater benefit so far than the VAD arm. And in particular, what was interesting is if you look at some of the clinical subgroups, for example, ISS stage, you can see that for ISS1 and ISS2, PAD followed by bortezomib for maintenance did have a trend for a benefit, but in particular, the greatest benefit was in the high-risk ISS3 category, where overall survival at 36 months was actually similar to that for ISS2 and a lot better than it was for the VAD followed by thalidomide arm. And the same thing was true for patients with elevated creatinine. And then looking at cytogenetic subgroups, you can see, I'm sure, the data about deletion of chromosome 13 and how bortezomib can be effective there. And you see that the PAD followed by transplant followed by bortezomib arm did have a very good progression-free survival and overall survival at 3 years. And the same thing was true in the 414 and interestingly in the 17p subgroup here. And this is, I think, important because most of the studies so far have confirmed that 17p is one of the highest risk groups in myeloma, and this is one of the few trials that has shown an ability to improve upon that, and hopefully this will be reproduced by other studies. Another combination one might want to think about for the future, in the US, what we often use now as a standard of care, even though it hasn't yet been validated in a phase 3 trial, is bortezomib with lenalidomide and dexamethasone. But one option for the future may be, instead of bortezomib, to use the second generation proteasome inhibitor carfilzomib with lenalidomide and dex. And I'll show you a little bit more about carfilzomib in the relapsed setting, but I thought I'd briefly show you this study for upfront patients. Carfilzomib is usually so far given on day 1, 2, 8, 9, 15, and 16. It is given as an IV like bortezomib, and in this study, dexamethasone was given once per week, and lenalidomide was given 3 weeks on, 1 week off, along with the standard len-dex schedule. The toxicities of this regimen, this was a phase 1-2 trial. I think the most notable finding is that the degree of peripheral neuropathy was quite low, and I'll get to that in a larger subgroup in the later studies for relapse disease. And the best responses to date, it's a small number of patients, 27, so I don't think we need to get too excited yet, but certainly a 96% overall response rate with 70% of people achieving a VGPR or better looks quite attractive. And the longer you stay on therapy, the better the response quality and overall response rate. You can see after 8 cycles, 83% of patients had a VGPR or better. And like bortezomib, carfilzomib does not have a negative impact on the ability to collect stem cells. And it may be that this combination will achieve a response quality comparable to bortezomib, but perhaps sooner and possibly with less neurotoxicity. And I know that the ECOG folks are thinking about doing a VRD versus CRD study in the upfront setting in the near future. There were a couple of also important, I think, developments in the transplant setting as well as in the maintenance setting. One of the things that my patients always ask me about, and maybe the same thing is true for you, they come and they say, you've got all of these new drugs now, do I still need to do stem cell transplantation? And it's been a very difficult question to answer because most of our transplant studies until very recently utilized older induction regimens that had a low rate of CR. But one way to try to address this was done by the ECOG folks. I'm sure that you know about their study where they randomized people up front to either len with high-dose dex or len with low-dose dex, and found that the low-dose dex arm, although it had a lower response rate, nonetheless had a similar or slightly better progression-free and overall survival, and certainly also had a much better tolerability profile. For this presentation, they went back and did a landmark analysis. And what they did is that they compared those people who went on to transplant after 4 cycles, no matter which one of the arms they went on, to those who continued beyond 4 cycles, no matter which arm they were on. And briefly what they found, now this isn't a randomized study, which I think is one fair criticism of the data, but what they found is that in younger patients, which they defined as under 65, you can see that the folks who went off to early stem cell transplant had a better progression-free survival as well as overall survival compared with the people who had later or no stem cell transplant. A similar trend was seen in the quote-unquote intermediate group, which was 65 to 70, and also in the older patient population, 70 or older, patients who got an early transplant did better than patients who did not. And actually, I think these data are quite compelling because normally one would think that perhaps the people who would go on to an early transplant would be the ones who were not doing so well on lenalidomide and dexamethasone induction, because if they were doing well, you would probably have a trend to keep them on that therapy. So if that reasoning is sound, which we'll know hopefully at their next presentation, I think it further makes the data more attractive. And although, again, it's not a randomized study, it at least gives you some reason to tell your patients that, yes, we have a lot of new drugs, but at least with lenalidomide-based induction therapy, transplant is still very helpful in terms of overall outcome. Another question that we've been bandying about in the transplant area for a while is whether autologous transplantation is the standard of care, or whether for some people we can do a non-myeloablative or so-called mini-allo transplant. And there was a report at this meeting from the BMT-CTN study, and you probably know that what they did is randomize patients to tandem autologous transplant or to autologous followed by a non-myeloablative allo. Now again, this is not necessarily a randomized study because some people could not get the non-myeloablative allo and so therefore went to the tandem auto. So in some ways it's a genetic, if you will, randomization. But the outcomes showed that progression-free survival was not substantially different for the 2 arms. Actually, maybe by a few months, it actually favored the tandem auto. And if you look at the overall survival, once again, no significant difference with a slight trend favoring the tandem auto. But there was, of course, as you would probably expect, a higher transplant-related mortality for the auto followed by a mini-allo. And if you were at the ASH meeting, you probably know that Keith Stewart stood up and said that perhaps this would finally put the nail in the coffin, if you will, of the auto followed by mini-allo approach. And of course, some of the transplant folks there were not quite ready to put that last nail in, but certainly the number of negative studies for this approach now outweigh the number of positive ones. And so unless we find a particular subgroup of patients for whom this approach is good, I think nonetheless we should think not about doing auto followed by mini-allo, certainly not routinely anymore. Now, there was a lot of, I think, interest in maintenance therapy, and in the past what we've done for maintenance post-transplant has mostly been thalidomide because of the IFM study that found the benefit there, and further back things like interferon and steroids were used. But the CALGB provided us with an update on their trial of lenalidomide in the maintenance setting. I'm sure you remember the design. This study has been presented now for a couple of meetings, but basically patients after induction therapy were randomized about 3 months after transplant to get either maintenance lenalidomide, which started at 10 milligrams continuously, no break, and no dexamethasone, and then later on you could either increase to 15 or decrease to 5, and the control group got placebo. There were about 230 patients on both arms, so a pretty substantially sized study. As you would expect, the people who got lenalidomide had a few more hematologic adverse events, and also a few more non-hematologic adverse events, although fortunately the grade 5 events were equivalent on the two arms. And if you look at time to progression, the people who got lenalidomide did much better in terms of TTP than people who got placebo. And also, one might think that perhaps if people got lenalidomide-based induction, they would have a lesser response to maintenance with lenalidomide afterwards, but in fact that wasn't the case, because the people who got lenalidomide induction followed by lenalidomide maintenance, which is the top blue curve, look like actually they're doing the best. The second best group were patients who did not get lenalidomide induction but got lenalidomide maintenance. And so in both cases, the patients who got len maintenance did the best. Overall survival data were not yet statistically significantly different, but you can see maybe the beginnings of some separation, and it will be interesting to see where these curves go in the future. And hopefully at this ASCO meeting, and then maybe some of you will be able to come to the myeloma workshop in Paris, hopefully we'll get more data about that. I mentioned earlier some second malignancy questions, and in this study there were actually 25 new malignancies reported. Out of them, 5 were cases of AML or MDS. They were coded together in the CALGB database, so far they haven't released information about how many of each. 2 of the MDS cases actually didn't get lenalidomide, which leaves us with 3 who did, so the difference really was only 1 patient. And a lot of the other malignancies were problems like skin cancers or prostate cancer. And I'll make one more comment about second cancers after this particular presentation. The other lenalidomide maintenance study was from the French. And again, I'm sure you remember their study. They did a little bit differently than the CALGB folks because they gave consolidation, if you will, lenalidomide to everybody for 2 months after transplant, and then they randomized to maintenance or placebo. And once again, they saw an improvement in progression-free survival. You can see about an 18-month difference in PFS for the len group versus the placebo group, and the overall hazard ratios look quite nice. Overall survival was still not different here, and hopefully with further follow-up there may be a difference. And selected adverse events are shown here. If you look at second malignancies, you can see that the people who got lenalidomide had more second hematologic malignancies as well as non-hematologic malignancies. The odd thing is that whereas the CALGB study mostly talked about AML and MDS, here there were several cases of Hodgkin disease in the lenalidomide maintenance group and also 1 case of ALL. Overall, if you look at the incidence of these second cancers, they are within the past history of what we've seen in the post-transplant setting, which I think would suggest that the numbers are not out of line with what we should expect. But certainly these do bear further follow-up, and hopefully there will be some preclinical as well as clinical studies to try to figure it out. But so far, at least the way I have read the data, I have not made a change in my usage of lenalidomide in the maintenance setting, and I've not told my patients to change what they're doing, although I do update them about this information. Now, in the relapsed and also refractory setting, the good news is we have some interesting new approaches and drugs coming. One of the new approaches is actually to use bortezomib in a slightly different fashion. And you probably have heard about this particular study, which was based on a previous French myeloma group trial, where they showed that subcutaneous bortezomib was feasible. And in this study, for relapsed patients, they randomized people either to IV or to sub-Q bortezomib. The doses and schedules were identical. The difference, of course, was that the sub-Q folks had injections either in their abdomen or in their thighs, and these were rotated in a fashion to make sure that patients did not get injections in the same location on consecutive doses. Looking at the response after 4 cycles, the goal of this trial was to hopefully show non-inferiority for the sub-Q version, and you can see the overall response rate looks identical, as do the various parameters like CR and near CR. And after 8 cycles, 52% overall response rate for both, so you don't need a statistician to be able to say that the results look pretty identical. Time to progression is shown here, and again, the results are almost identical, and survival at 1 year is shown in the inset. Still, we need a little bit longer follow-up, of course, but it certainly looks like the benefits are similar, and the TTP numbers, if you look at the bottom, seem to favor maybe even the sub-Q version by a little bit. Adverse events were seen in both arms, of course, but overall, the IV version had more grade 3 and 4 adverse events than the subcutaneous version. And I think where things really get interesting is in peripheral neuropathy. You can see that the overall incidence of neuropathy was substantially decreased, and the grade 3 and 4 neuropathy was decreased by half. And so certainly this looks like potentially an attractive way to give bortezomib that may be able to give you the same efficacy but much better tolerability, and hopefully it will lead to combination studies with this subcutaneous approach in the future. Earlier I showed you some of the data about carfilzomib in the upfront setting, and mainly where carfilzomib has been looked at is in the relapsed setting. And there was an update of this study looking at patients with relapsed and refractory myeloma, and these data hopefully will soon be filed with the FDA in the US and hopefully will support approval of carfilzomib. As I mentioned earlier, carfilzomib is given on day 1, 2, 8, 9, 15, and 16. And there were 2 different ways it was given, but probably what should be done is in cycle 1, it was used at 20 milligrams per meter squared, and starting with cycle 2, it was given at 27. The reason for this is that in some of the early studies, it appeared that there were some cases of either tumor lysis or other causes of renal insufficiency which did not recur after rechallenge. So the concept was to give a lower dose with cycle 1 and follow it with a slightly higher dose in cycle 2. You can see that these patients had a median of 5 prior lines of therapy. 100% had prior IMiDs, and virtually 100% had prior bortezomib. So these were really a heavily pretreated group, and many of them had more than 1 prior line of bortezomib-based therapy. If you look at the overall response rate, it was about 24%, including PR or better. If you include minor responders, it turns into 34%. And if you take stable disease patients, you get 70% of people with stable disease or better. Looking at some of the subsets, you can see that in unfavorable cytogenetic patients, as is true for bortezomib, carfilzomib had a similar overall response rate compared to people with favorable cytogenetics, and peripheral neuropathy at baseline also did not impact on the overall outcome. In other subsets, it looked like if you had 1 prior bortezomib line of therapy, you did well, although for patients who had 2 or more prior lines containing bortezomib, the response rate with carfilzomib did drop off, suggesting that there is probably some cross-resistance. Here you can see progression-free survival, and of course the patients who got VGPR or better did the best, with an almost 1 year progression-free survival, whereas people who got PRs were about 9 months, and for the group overall, it was between 3 and 4 months. And overall survival, interestingly, was quite good in this patient population, with 5 prior lines of therapy, with a median of about 1 year and 3 months. So as I mentioned, hopefully this will lead to carfilzomib's being approved in the relapsed and refractory setting. And as was the case in the upfront study where I mentioned that neuropathy was relatively low, here what we see is a 12% rate of neuropathy overall, with 0.8% having grade 3 or 4 neuropathy. So hopefully this will be borne out by additional studies as well. The other interesting thing about carfilzomib is that there is a slightly different dosing regimen that's being looked at, which includes a 30-minute IV infusion rather than a several-minute bolus. And in a phase 1 study, which is still fairly preliminary, it looked like a higher dose of carfilzomib could be tolerated, and it looked like more patients were responding. So hopefully we'll see more studies with this schedule in the future. Moving on to other approaches, we do know that immunomodulatory drugs like lenalidomide work very well. We haven't had a lot of information about retreatment with lenalidomide, but at this meeting there was a little bit shown, and you can see in the little panel on the right that for patients who had a lenalidomide-based therapy as their first line and then eventually relapsed off of lenalidomide, if they were put back on a lenalidomide-based therapy, most of this was Lendex, they still had a very nice time to progression over 1 year. So this does suggest that retreatment with lenalidomide can be effective, and we do know, of course, that the same is true for bortezomib. Other options that you may consider, we've actually been doing an interesting study with the combination of lenalidomide and thalidomide and dexamethasone. Now you might ask, why would you even think to do that? And part of that is because of some preclinical studies we did in the laboratory that looked at the mechanisms of resistance to lenalidomide. And what we identified based on gene expression profiling was that activation of the Wnt beta-catenin pathway seemed to be involved in lenalidomide resistance. And one of the ways that we have to suppress that pathway actually is thalidomide. So even though the drugs are chemically similar, you know that they're different because the toxicity profile is different. And based on the fact that thal could suppress what looked like the resistance mechanism for lenalidomide, we put them together. So we did a phase 1 study, and the dose that we wound up deciding on using for phase 2 was the standard lenalidomide at 25 on days 1 to 21 out of 28, and thalidomide at 100 milligrams daily. We gave high dose, the old standard pulse dose dex, in cycles 1 and 2, and starting with cycle 3, we went down to the weekly dexamethasone. And in the phase 1 portion of the study, the overall response rate was 92%, and in patients who were lenalidomide refractory, we had an 80% response rate. So hopefully we'll be able to update this experience at ASH this year, and I can tell you that the numbers still look very attractive. And so hopefully this will be another combination where you can put together drugs that you may have used in previous lines in a new regimen that will get some nice efficacy. Another approach may be to use some of the newer immunomodulatory drugs, and pomalidomide I think is the one that is closest to getting approved. And there were a couple of presentations about pomalidomide. I pulled out 2 of them. One was from Paul Richardson, where they did a phase 1 with pomalidomide on the len schedule, days 1 to 21 with the 4th week off, and then dexamethasone could be added later if patients had suboptimal disease response. You can see here median prior lines of therapy was around 6 to 7, so really a very heavily pretreated population. Adverse events with pomalidomide are pretty similar to what you would expect with either thal or len, including cytopenias, some neuropathy, and also a risk for thromboembolic complications. Dose-limiting toxicities are shown here, and ultimately Paul and his group felt that 4 milligrams was the appropriate regimen for further study. And in the phase 1, you can see that the response rate at 4 to 5 milligrams was about 25 to 30%, and if you included minor responders, it was about 55 to 70%, whereas in the phase 2 setting, the overall response rate was again in the 25 to 30% range. Another pomalidomide study was presented by the folks at the Mayo. They did pomalidomide with low-dose dexamethasone, but instead of the 3-week on, 1-week off schedule, they used pomalidomide continuously with the low-dose dexamethasone given. These patients had a median of 6 prior lines of therapy, and you can see the overall toxicities were somewhat comparable for the 2 milligram and 4 milligram groups, although maybe the 4 milligram group had more serious thrombocytopenia and neutropenia. Other toxicities were relatively manageable, although fatigue and neuropathy were seen. And the response rate was pretty similar to what Paul had presented in that 25 to 30% range, which is actually the same range that carfilzomib was in. Outcomes, you can see median time to response was very rapid, durability was quite good, and survival at 6 months was reasonable considering these were folks with 6 prior lines of therapy. One of the, I think, more interesting drugs coming in the pipeline is elotuzumab, which is a monoclonal antibody directed against CS1. And we haven't had a lot of antibodies to play with in myeloma. One of the other ones that I think is attractive is called siltuximab, which is an anti-interleukin-6 antibody. And we're hoping that we're going to have data from a randomized study of that agent with bortezomib in the relapsed setting available for presentation at ASH. With regard to elotuzumab, there was presentations from a randomized phase 2 study looking at 2 different doses with len-dex. The len-dex was the standard low-dose dex regimen. Elotuzumab was given weekly in cycles 1 and 2, and then every other week starting with cycle 3. Again, they compared 2 different doses of elotuzumab. You can see that the response rate was maybe actually a little bit better with the lower dose at 90%, which is quite good. And 32% of patients had a VGPR or better, with a low rate of patients having progressive disease. And these were seen both in prior thalidomide-treated patients as well as prior bortezomib-treated patients, although the response rate was lower in people with prior lenalidomide exposure. And the progression-free survival data are not yet mature, but at least so far look fairly attractive. And the major adverse events that are different than just len-dex are some infusion-related reactions, which can usually be treated quite successfully with the standard pre-medications, including a little bit of steroid. And there is a phase 3 study with elotuzumab len-dex versus len-dex that is being planned in the US. Also, briefly, I wanted to mention one other drug that we're interested in. It's a kinesin spindle protein inhibitor. And for those of you who don't remember, which I never did until I got involved with this drug, but what KSP actually does is when the cell divides and the microtubules form the spindle, in order for the chromosomes to separate, KSP has to actually pull on the microtubules so that each daughter cell gets the necessary amount of information. So if you will, it's kind of like the motor for the spindle. And there are drugs that inhibit that, and we've been interested in this agent called Array 520. The reason that we're interested is, first of all, there is nice preclinical data, and clinically this drug has no neuropathy because KSP is only expressed at G2M, which means that neurons have no KSP at all. So hopefully, and what we've seen so far, it's true, there is no neuropathy. And we have seen partial responders in patients with prior len and bortezomib. It's been well tolerated generally, and we're going to have an update of this at ASH. And then finally, in the supportive care arena, there was one study that I thought was interesting, which was the large MRC trial, which looked at intensive versus non-intensive therapy, but also compared clodronate versus zoledronate as a bisphosphonate for bone disease. And what they found, interestingly enough, was that there was a slight trend which was statistically significant favoring zoledronate with about a 5.5-month improvement in overall survival compared with oral clodronate. And the hazard ratios for overall survival and PFS both favored zoledronate, and the impact of treatment, whether this was intensive therapy for younger patients or non-intensive therapy for older patients, still favored zoledronate over clodronate. And interestingly, if you look over on the right side for patients who got MP, there even looked like there was a better CR and VGPR rate for people who got MP zoledronate versus people who got MP and clodronate. Skeletal-related events were better with zoledronic acid than with clodronate. And interestingly, over on the right curve, even patients who had no bone disease at baseline, who based on the ASCO criteria we would now not treat with bisphosphonates, had a lower rate of bone events on zoledronic acid compared to clodronate, which may provide some rationale for treating even patients with no bone lesions with bisphosphonates. So in conclusion, before we get to questions and also a little bit of dinner later on, let me summarize what I think we've recently learned. First of all, in the asymptomatic patients, we know that we can identify people who are at especially high risk, and they may benefit from Lendex, although I think we need more follow-up, and we still need to know about the impact on later stem cell collection and the possible induction of drug resistance. And I still think that this is an area where clinical trials would hopefully be fruitful. For transplant-eligible induction therapy, we know now that a better induction regimen before transplant improves the outcome after transplant. We know from a number of studies that bortezomib and dex is better than VAD, and I showed you that PAD is better than VAD. We also know that VTD is better than TD, and it may be that bortezomib with lenalidomide and dexamethasone may be even better, although the phase 3 study to compare Lendex with VRD has not yet finished accrual in the US. We still have lots of questions. Should everybody get the same regimen? Is VRD right for everybody? Or is there some way to predict who would do better with regimen A versus regimen B? And we still don't know whether complete responders are people who should get transplant or not. For patients in the post-transplant and maintenance setting, it looks like still early transplant is of value, and auto should be the standard of care. And maintenance with lenalidomide certainly looks attractive, although we don't yet have overall survival benefits. And I think the second malignancy question still bears scrutiny. For patients who are not transplant eligible, earlier use of novel drugs has lots of benefit. We have a couple of triplet combinations, including MPT and MPV, and now we have MPR as well. Although we still don't know, as for the transplant-eligible people, whether we can identify which people will do better, for example, with MPV or MPR, and hopefully at some point in the future we will be able to. We do know that these novel agents are making a big impact in the upfront setting. You can see that the overall survival curves are being shifted rightward, which is what we want to have happen. And then for relapsed and or refractory disease, right now, lenalidomide and dex or bortezomib with liposomal doxorubicin are still the standards of care. You also can reuse drugs that worked before and sometimes combine them into new regimens. And we have new drugs like second and third generation IMiDs and proteasome inhibitors that are coming, as well as drugs with novel mechanisms of action. We actually have a lot of drugs now that we can play with, and hopefully all of them will find their way into our toolkit against myeloma, although I think we still need to do a lot of science to try to figure out whether we can predict which patients, for example, will do better with an HDAC inhibitor versus another combination so that we don't expose patients unnecessarily to toxicities. And also in the relapsed setting, we can say that we're making some headway because these patients are doing better over the last few years than has been the case in the past. Also, if you ever have questions and you want to either refer patients to MD Anderson or you want to get in touch with me personally, we have a actually toll-free referral line, which is 855-myeloma, not too difficult to remember. And then we've got actually 6 faculty that focus on myeloma, and you can easily contact me by email if you have any questions. I'm happy to help out. For those of you who tweet, I have a Twitter account, and I try to tweet about myeloma updates, and my handle is myeloma_DOC or doc. So hopefully you'll be able to join me, and we'll all get the word out about the good news for myeloma. So thanks very much for your attention, and I think we have a little bit of time for questions if there are.